medicine too. Starting with the case scenario, Mr. S, 72-year-old gentleman from Vallur, who's a retired sub-inspector, presented with complaints of new onset headache and weakness since 8:30 p.m. The headache was sudden in onset. It was over the left side of the head. It was associated with 3 episodes of vomiting. And he also noticed that he had difficulty in lifting his head overhead and walking since 8:30 p.m. He didn't have history of seizures, LOC, no blurring of vision, no diplopia, no deviation of angle of mouth, no drooling of saliva, no cough while eating food. There was no history of other sensory disturbances, no bowel and bladder disturbances. Past history, he was a hypertensive on regular medication. He didn't have any other comorbidities. So examination, when he came here, his BP was 130 80 with millimeter of mercury with other normal vitals. Other examination is he was conscious, oriented to time, place, and person. Initially, when we assessed for language, it was normal. Memory, his remote memory was impaired. When we asked about his date of birth, he actually mentioned that he was born in 1972 when his age was actually 72 years. But he remembered all his old events that has happened, his marriage, his daughter's marriage, everything he remembered. This few things, memory disturbances he had related to remote memory. He is right-handed. As for the cranial nerve examination, he didn't have any cranial nerve deficit. Motor examination, his power of 3/5 in right upper limb and 4/5 in the right lower limb, and left lower limb it was normal, and reflexes were exaggerated on the right side with the plantar extensor. He didn't have any sensory symptoms and no cerebellar symptoms. He didn't have neck stiffness, meningitis, skull and spine. The skull and spine was also on the normal. So our diagnosis was acute stroke syndrome and this cranial nerve examination. One thing I'd like to mention, on examination, his pupil was bilaterally equally normal reactive. In visual field examination, he actually had right homonymous hemianopia. So with the syndrome of acute stroke syndrome with right homonymous hemianopia and right hemiparesis, our diagnosis was posterior circulation stroke, mainly involvement of the occipital lobe with the thalamus. So this right homonymous anopia, I wanted to explain about the approach to the visual field abnormalities. So coming to the visual pathway, so this visual pathway usually starts in the retina, followed by the optic nerve. Then comes the optic nerve, followed by optic chiasma, then optic tract, lateral geniculate body, optic radiations, and then primary visual cortex. As we all know, in the eye, the representation is actually in the opposite. For the temporal, it is actually in the nasal side, and in the nasal, it's in the temporal side. It is represented, and in the optic chiasma, there is crossing of medial fibers, and then it is followed by optic tract, and then lateral geniculate body, optic radiation, and the primary visual cortex. So what all tests to do in the visual pathway defect? So first we should think of the visual acuity, color perception, visual field examination, fundus examination, and pupillary right reflex. So with these 5 things, we'll be actually able to differentiate the visual pathway defects. So coming to the localization in the retina, usually visual activity is usually normal unless macula is involved, and the color perception, as per the lesions are affected, if the receptors are affected, they'll have color perception defect also. In visual field damage, if there is certain field is involved, they'll have visual dip as per the defect of the retina. And light reflex is usually normal, and fundus will be able to see the focal retinal changes. In the optic nerve lesion, visual activity is usually decreased and color is also affected. And visual field, because of the optic nerve involvement, they'll have decreased the monoocular visual field abnormality will be there, and light reflex usually RAPD will be present, and fundus usually disc edema and optic atrophy, if it is long standing, will be present. So coming to optic chiasma and the optic tract, visual acuity is usually decreased, and this color perception, because of the optic nerve involvement, there is no receptor damage per se because of the long standing optic compression. Because of that, they have mentioned that optic nerve damage, because usually red color perception is usually affected if the optic chiasma is involved, is what they have mentioned. In the visual field, because of the crossing of the fibers, there will be bitemporal hemianopia, and light reflex is also impaired if it is in the lateral chiasmatic lesions. The fundus usually will have bow tie configuration. This actually means that the part of the nerve that is affected because of the long-standing compression, there is atrophy. In the retina, it will be visualized as the atrophy of the retinal optic head. So that is called bow tie configuration. This bitemporal hemianopia is usually specific for optic chiasma. It is not seen in other visual field defect. As for the optic tract, As I mentioned, this visual acuity will be usually normal, and color perception, as I mentioned earlier, because of the long-standing compression, they have this red color perception is usually affected. Other colors are not usually affected. And visual field, contralateral homonymous semionopia is present, and light reflex is impaired. In fundus bilateral segmental optic atrophy, it is because of the same, this long-standing compression, there is damage to the optic nerve. Because of that, they have atrophy. So now this lateral geniculate body and the optic radiation in this visual acuity is usually normal. Their main problem is mainly only the visual field defect. So contralateral homonymous hemianopia and light reflexes usually it can be impaired or it can be normal also, and fundus bilateral segmental optic atrophy can be present. So this optic radiation, for them the main problem is only the visual field. It actually has two lobes, that one lobe goes into the temporal lobe and one lobe goes into the parietal lobe. And the inferior fibers goes into the temporal lobe. Because of the, if it is affected, they will have superior quadrantanopia. If parietal lobe is affected, they'll have inferior quadrantanopia. Now coming to the calcarine cortex, the primary visual cortex. So in this, visual acuity is usually normal, and the color perception, because of the primary visual cortex is affected, they won't be able to differentiate the color. And visual field, they'll have contralateral homonymous semionopia with macular sparing, and light reflex is usually normal and fundus is usually normal. So why this macular sparing is because posterior cerebral artery supplies the primary visual cortex, but this macula is usually supplied from collateral from the middle cerebral artery. Even if the bilateral cortex is usually involved, macular sparing can be spared because of the collateral from the middle cerebral artery. So this is the visual field defects in the pathway. So if it is retina, they can have central scotoma if the macula is involved. If there is optic nerve, monocular vision loss will be present. This is the optic chiasmal lesion. There is bitemporal hemianopia. Actually, contralateral homonymous hemianopia can be seen in 3 lesions. One in the lateral geniculate body, one in the optic radiation, and another in the primary visual cortex, which will usually have macular sparing. So our patient finding, he had right homonymous hemianopia suggestive of left lesion. It could be either in the lateral geniculate body, it could be in the optic radiation, or it could be in the primary visual cortex. This macular sparing, usually we cannot differentiate it clinically unless we do perimetry. And he also had color agnosia. So when we asked what color is the sky, he was able to tell it is blue in color. But the chair was in front of him, it is blue in color. He is not able to tell the color. He said it's yellow in color, and it said it's green in color. He is not able to tell it properly. And he also had memory disturbances in the form of remote memory disturbance. And he also had something called anomic aphasia. So when we asked what will he use for sitting, he mentioned chair, but the chair was right in front of him. He is not able to answer. When we asked what will he use for drinking, he said we will use tumbler and water bottle. But when we showed him a water bottle, he was not able to name the bottle. So he actually had visual anomic aphasia. So he, along with the right hemiparesis, he had this all 4 findings. So our patient localization was for the right homonymous hemianopia. It was it could be either left occipital cortex, left optic tract, or left lateral geniculate body. Color agnosia, it is focused mainly in the occipital cortex. As for the memory disturbance, it is localized to hippocampus. Anomic aphasia, angular gyrus. So our localization mainly to the posterior circulation involving the temporal lobe, occipital lobe, and part of the parietal lobe. This we are not able to explain with the angular gyrus. So this is our localization. So coming to the posterior cerebral artery supplying area, so P1 segment supplies the thalamus, and for the right hemiparesis, we had only 2 localizations mainly. Because of hemiparesis, it was only thalamus and the pontine lesions. Because pons, he didn't have any other cranial nerve involvement, thalamus was the only thing we thought of. So coming to the posterior cerebral artery supply, so P1 segment supplies the thalamal perforating arteries. So our patient could have had PCA infarct with the thalamus infarct. P2 segment supplies the direct peduncular perforating arteries and mainly the hippocampal artery. So if it is affected, the memory disturbance could be there in our patient. That is also explained. And P2P segment is not there. P3 and P4 segment supplies the calcarine artery. If it is affected, he could have had occipital lobe infarct, and parieto-occipital artery, if it affected, angular gyrus could also be involved. So all the findings are explained with the patient having this PCA. So our localization was to occlusion in the posterior cerebral artery. So our patient MRI showed infarct in this is hippocampal region, and this is the thalamus, left thalamus, and this is the occipital region. Unfortunately, angular gyrus was not involved, but then we went through the literature and we found out that the supply from the dominant occipital lobe goes to that visual reflex lobe goes to the angular gyrus. If that supply is cut off, they can have visual anomic aphasia. So our MRI also revealed this attenuation and cutoff of the left PCA territory, confirming the localization of our finding. So our patient had area of diffusion restriction in the left thalamus, left occipital region, and left posterior temporal region, suggestive of acute infarct, diffusely attenuated left posterior cerebral artery. So I'd like to also explain about two syndromes in occipital infarct. So one is Balin syndrome and another one is Anton-Babinski syndrome. So Balin syndrome has a triad of optic ataxia, psychic paralysis of gaze, and simultagnosia. So optic ataxia, if we are given an object, the patient won't be able to see the surrounding in relation to the motion. So if we ask them to take the object, they won't be able to take it from our hand. It's different from cerebral ataxia because it's in relation to the motion and not like cerebellum. And psychic paralysis of gaze, the patient usually doesn't have any extraocular movement abnormalities, but it's like more like apraxia. They won't be able to move the eye if you tell them to move. That is psychic paralysis of gaze. Simultagnosia, if we show them a scenario, they won't be able to correlate the scenario properly. They'll be able to say only the object that is present there. So anybody from the audience can tell what is going on here? So it's in the kitchen. A lady is washing his dish and there is water pouring down from the wash basin, and the children are trying to take a cookie from the drawer. So if this is what we normally see, but if we ask a patient with Anton syndrome, Balin syndrome to say it, they'll be saying that the lady is only standing there. They won't be able to see the whole picture of the kitchen. So this is simultagnosia. So coming to the Anton syndrome, the patient will have clear vision abnormality, but they will completely deny it. And even if we asked about something related to the memory, they will also confabulate, like how they do in alcohol confabulation. They will create new memory with the visual perception and they will tell it. Our patient didn't have Balin or Anton syndrome. I just wanted to update about it. Thank you.
Nice presentation. You want to clarify or ask something? Very nice clinical examination and presentation of your patient. I'm supposed to choose the best out of the four and give. Okay.
Why do you call it a paradox? There's no paradox.
I'm supposed to choose the best of the four. Everybody did a very good job. I think since it's a little, I think you're going to the last presentation, a lot of clinical